Hi, I'm Laura Redman from Cape Town, South Africa, and welcome to another episode of the Radcliffe veinPODCAST. Our Hippocrates quote and topic for today is, "Life is short, the art long." And it's about the benefit of a multidisciplinary team approach in vein and lymphatic disease. Now, the reason we are doing this subject this week is because it's International Vein Week, and venous and lymphatic disease has grown exponentially in the last 2 decades in terms of research and intervention, and they go hand in hand. And one of the big issues is awareness. And more so from our side, I think it's the combination of venous and lymphatic disease and not just starting a vein clinic. So on the podcast today, I have my mini multidisciplinary team, which is Khaya Seleteng, who's a vascular technologist. He's also a cardiac perfusionist in his previous life. He no longer does that. And Sister Emily Abendanon, she's a wound care nurse and a lymphoedema therapist and does all our procedures in the practice as well. So the multidisciplinary idea is slightly different because when one thinks of a multidisciplinary team, you think of different specialties working together. And we actually a multidisciplinary team in one specialty in essence, which is the vein and lymphatic clinic. And I'm going to give a little bit of background and then start to involve the others in that when I first started with the vein clinic, doing superficial venous disease, and I would scan on my own, treat patients on my own. So it's very isolated in that way. And as it grew, I got Khaya involved and he used to scan. And then we did procedures together and we would discuss patients and build up the deep venous system and get our own protocols. And then Emily joined, and with her background of wound care nursing, as we did a lot of venous ulcers, etc. And then she specialized as well as a lymphoedema therapist, and we treat lymphoedema, and that came lipoedema, and we all do malformation. So it's quite a broad range. So I wanted to ask both Emily and Khaya, from a nursing and a technology perspective, what do you see in the benefits of working in a multidisciplinary team as opposed to where you could have been working elsewhere?
Okay, for me, what's really the benefits for working in this multidisciplinary team is that as a multidisciplinary team here, it's I'm involved in every journey of the patient, from the day the patient comes into the doors, where the patient does is consulted, scanning, and also in the planning of the procedure. And also during the procedure, I'm also involved in part of that. And also the follow-up of the patient, the scanning, just to know the whole picture of the patient. So I always know what's going on with the patient. So I think that has helped me a lot just to get the full picture of how the patient and the disease which we are managing, like the venous. Because in the previous, maybe if I had worked in another place, just do the diagnosis, you are not involved in the planning of the procedure or any inputs there, and not involved also in the operation of the patient. So I think that's really great with this team approach we have here.
Getting the whole overview and seeing the patient. Yeah, I always think that with you used to see the inside of a patient through a scan, and now you can see them clinically and surgically as well, which is good. Okay, let's start there. Emily, what do you find any benefits in terms of the multidisciplinary, and what is beneficial?
Yeah, so I think I would definitely back Khaya in terms of we all get to see the patient. So from the minute the patient walks in through the door, we get to see them at assessment. We get to see them probably during a procedure, and then we get to see them afterwards and follow them up. It's kind of almost a one-stop shop, almost, if you kind of put it like that. Patients can come to our rooms and they can have everything done at once. They can see Dr. Redman, they can see Khaya for their scanning. If they need anything in terms of help with swelling of any types or edema or wounds, they can see myself. So it's not like in other places where I worked before, where we have had to refer patients out and then deal with a whole load of other practitioners, which is not an issue at all, because we still obviously refer patients to other practitioners. but I think it's also for a patient, it's quite nice for their journey as well, and nice for their condition if they know that we're all involved and we discuss our patients regularly. And we're always coming up with new ideas together, because we've all got a bit of a different background in things. So we all do our own kind of learning on the side, and then bringing it all together.
Okay, thank you. Well, that's all positive feedback for our practice. I guess we don't have somebody arguing against it, but yeah, I think that is part of the whole team in terms of venous and lymphatic, and again, and how it's different. It is a subspecialty of vascular with the division. So I think the one problem with doing a specialty in any way is you can go down one road and you're not aware of what's going on around you, which us three altogether, I suppose, could do as well. And that's why we have to, still link to outside disciplines. But I think education is important, and we all teach each other in different ways, and we see things in different ways. Khaya, if you scan and you see the physiology more, than when we do a venogram or something like that. So I think that helps. Do you think there's any negative sides to working as such a team, or any ways that might not be beneficial to a person?
Yeah, I think maybe like what you said as well, we almost potentially maybe get stuck in our own kind of ways of doing things. I know we've got protocols for most things, but I think that's one of the things when we're treating something like, say, lymphoedema, for example. Different therapists have different sort of tricks and stuff, if that makes sense, and different ways of doing things. So I guess, like I say, one could say that if I had my way of doing something, then it's just the way I always do it. Whereas sometimes if you reach out to someone else and you explain, the case and stuff with them, they might have another idea of how to also treat the patient. I think that's probably from my side.
Emily, I agree with you, and it's good because I think there are points that we actually need to debate within ourselves, which is right. So you firstly quite linked to LAOSA, which is the Lymphatic Association of South Africa, and you will discuss with other members of the team there if you have an issue. But I'll argue against your point, and I think it's beneficial if Khaya and we might see things from a different perspective. For me, if it's been from a surgical side or, something I've seen when examining a patient, I might relate it to another aspect of medicine. And Khaya would see from his scanning, even in lymphoedema, we've asked him just to check if there's fluid in a tissue. So we know, has the lymph really been drained to a significant degree or decongested in that way? So I think the key thing is actually what you're doing. We have our team and we can feed and work off each other because we come from different backgrounds, but we have to still link to other people in our own disciplines and still grow and be educated in that way.
I also see Emily's point, if maybe because especially on this team, maybe I'm the only technologist here in the practice. So maybe without reaching out to other people, seeing how maybe what new things they have encountered, what new things they do, what new physiological things they see in different patients, just those discussions, I think they do help to see different views. I'm not maybe it's just one of those I think it's a downside about this, but it's also good. But it's even though I don't connected to most of my other people, but I do go out now and then scan in other practices, but just to see how they do things. But what we also like about what we do, we also do a lot of webinars, international webinars. So I do get a lot of also other information from all over the world, how they do things with regards to scanning, even with operation and the planning. So I think that's also part which is very good about this setup.
Okay, no, that's good. And I think, both of you are quite driven on education as well, but in another way, it is a unique setup. And Khaya, I've mentioned this to you since you've been with me, in that and now it's three of us that we all involved with the patient, from the beginning to the end. And you all know what I look for in a patient. And so I understand scanning, but you understand clinically. And Emily, you've taken over a lot of clinical work, and then you've given us information on bandaging and decongestive and wounds, which we've all learned from each other. And we all try to grow in education in our own way. And I actually think that's where venous and lymphatic clinics should go. It shouldn't just be superficial varicose vein clinics. A lot of those exist. That must be a branch of everything, but we've seen many times the overlap of venous and lymphatic disease, or venous and disease and lipoedema, or when we see the malformations, there's an overlap of a lot of venous and lymphatic. And I actually believe it's not always practical. You need that team. So you can't run a clinic without a technologist who knows how to scan, without a wound care nurse, without a lymphoedema therapist. So Emily, you're just 2 in 1 for us. But that's ultimately, it's going to grow how clinics should, and I feel there should be teams almost replicated. That's how I would envision it growing, as we understand things more. And then we all put our heads together. I don't think you can get all the rules and regulations and how patients should be managed just coming from a surgical side. You need everybody's input because we all see the patient. So I think we should replicate our clinic, but maybe just for the audience as well, and it's because it's Awareness Week, should just mention a little bit of the overlap or some of the subjects, how we all see them. So Emily, do you want to chat about lipedema or lymphedema and how we all just a little bit of awareness about it, how we investigate them and manage them?
Sure. So, we look at our patients very from different points of view, definitely. So if they come in with swelling of a limb, we don't just look at it as, oh, it's lymphedema. We investigate it more thoroughly, definitely. So Khaya will always do a scan to check the veins to see if there's any venous component that might be causing swelling. And if it's a patient who we suspect might have lipedema, he also does a lipedema scan to measure tissue distances. And he's come up with a really nice table that he puts everything in that's from overseas, I think. And it's a big growing area, things like lipedema. It's still especially in South Africa anyway, it's still a very new condition that not many people know about. So we've been looking at ways that we can, like I say, treat this person kind of altogether. And if there is a venous component, like I say, that's attributing to something like the swelling, even maybe they might have a venous component with the lipedema, not that it's the same, they're different conditions, but then we would always want to go in and help to treat the cause. So like I say, for example, if it is someone who's got a lot of swelling and Khaya finds that there is venous incompetency, then we can hopefully try and, if it's superficial especially, then we can try and hopefully resolve that superficial incompetency and reflux, which will definitely help with someone's swelling. And then I can come in as well and I can do their decongestive therapy before they have their procedure if they need it. And then also make sure that they've got the correct garments to wear afterwards. Again, like I say, all quite new things, new areas, but we all work together to try and make out the best treatment plan for our patients.
I think that is fantastic. And if you guys think there should be somebody else in the group or in the team, who would you think, or what discipline would add value to a venous and lymphatic clinic?
From my point, I think like the involvement of like podiatrist and maybe like biokineticist, because most of the time it's limb swelling, what we've realized like most of the time, which is not really, most people don't pay attention to this, is the way the patient walks, their gaze, and like the failure of the calf muscle pump if they are walking. So that's like one of the major causes of limb swelling when the patient don't use their calf pump muscle. So I think with the addition of those biokineticists and maybe podiatrists, then we can help like to find a way to correct that, to make the patient be able to use their calf muscle pump. So that's what I think can also add value to.
I would have said as well to help. I mean, it's such a problem area is that so it's patients really have foot issues, knee issues, or are elderly and obese. You don't activate their calf pump. We need to get someone involved to help. So I agree with that. And I think the other element that's coming into all clinics everywhere is the overweight and obesity. So we've started to see a lot of those ones and try and get it almost a separate little multidisciplinary team for them. Emily, do you just want to mention those?
Yeah, so like you say, we've been seeing patients with venous conditions, maybe even some lipedema and some lymphoedema as well, where they are classed technically as obese. There is quite a big connection between lymphatic conditions and vascular conditions when it comes to obesity. And again, that's one of the ways of looking at our patients holistically, is that we help them to treat the cause, so we can help them with their veins and stuff, but we also need to try and help them with their weights, so that they can get to a BMI that's more in the that's healthier for them and less risky for them. So we've been looking at developing a group for our patients in the practice that's run by a psychologist who we've worked with a little bit as well. She's worked with some of our lipoedema patients too in a successful support group. So we're now trying to make the same thing as well for patients who need to have some support with their weight loss as well. And with that, we've been also looking at developing like a plan that can go along with them, that involves things like setting goals, how to set goals, keeping motivation up, and yeah, because I think again it's an important component to be looking at that as well, not just their legs and their veins.
No, thanks, Emily. And I think I must compliment you as well on your work you've done. So the one issue that then arises with that, so we've all mentioned, have a podiatrist, have a biokineticist, there's a psychologist. Sometimes we send to physio, sometimes to an orthotist. But for a patient, they can't go to all those places, and then it becomes exceptionally expensive. So I think that's thought about it as well, how we manage that. And I think that's every practice needs to actually have some form of lifestyle management or preventative medicine for their patients. And I think in essence, that's what we've been trying to bring in, but then we need to have the knowledge about it. So you've started with plans and, food things we'll do adipose scans or lipedema scans to help people become aware of where they're at, what their goals should be before sending them out. And only when they're ready, then let them, go to another place where they can also be able then to gain value and be prepared to pay for an additional service. So I think that's part of what most clinics should keep in mind, as well as keep the lifestyle and preventative medicine part of it. Okay, so again, I'm going to highlight the International Vein Week awareness and just bring in something that's been newer. Khaya, do you want to chat a little bit about the malformations? Because we've been seeing more and more of them, and we believe they're more treatable, but we never used to see it. Again, there was a lack of awareness, or we used to just manage venous and lymphatic malformations with compression and very conservatively, unless they were life or limb threatening. And in that way, again, Khaya scanned the patients I've seen. We've read the MRIs together. He's come to theatre with me when we do venograms or treatment thereof and manage them post-op. So you want to just mention a little bit about what we see and how we've grown in that way as a team and what we've developed?
Okay, so because with malformations, like it's quite like Dr. Redman has said, it's a quite a fairly new thing to us and also me. Like since I've started scanning, so it's also just a new ground, but there's been a lot of lack of awareness. So even for myself, so but like since we have started seeing malformation and doing them, we found that there's quite a lot of people in the country with venous malformation, and some also like they do affect the quality of life of people. Even like so, we've just like done a lot of stuff. So I do when the patient comes, like as Dr. Redman says, we just we mostly do the MRI just to see the extent of the malformation, and maybe it's like delineates what type of malformation. But much we've mostly done is venous malformation. So like on scanning, like we just look at what types of malformations we can see. So like they're usually just abnormal growths of veins, which are usually which usually happen maybe during birth or embryology. So like some veins which are not connected to the main system of the venous drainage. So they do some of the venous malformation, they're not part of the normal venous system. So they don't drain with the normal venous, they just venous pockets which just carry blood. Then some can cause discomfort or pain to patient who's suffering from them. So which can lead to patient maybe even like if maybe the malformation is around the knee, which you've seen, so which can lead to the patient not using that limb. So a patient can end up developing a contracture. We've seen some of that. And so like as we've learned, there's now malformations are treatable. So like this can help like prevent patients from reaching the stage where their quality of life is affected, or to correct them when they already reached the stage. So like, but we've quite some success with some of the patients we've treated for the malformations.
No, I think it's true. And the more we start seeing them, the more we see. And it is definitely beneficial to create that awareness. It's like everything in venous and lymphatic, it's more about improving the quality of life than not necessarily limb saving or life saving procedures. Okay, good. So those are generally children, picked up usually as discolorations or round joints if they start, getting immobilization or limping or anything like that, that should be investigated. And we'll generally treat with alcohol sclerosant, but sometimes coils and other interventions are necessary. And that's where Emily then came in again as part of the team, because most of those patients need compression. And as most of them are children, they need custom-made compression. Emily, do you want to chat a little bit about that at all?
Sure. So the compression sometimes is actually quite tricky because, well, the patients that we've seen so far, that I've seen so far, whilst I've been at the practice, have all been children. A lot of compression companies don't make ready-made garments that would fit a child. So a special one has to be made. So we have to take, and this is actually where I usually involve an orthotist to come and help. The orthotists have a wide range of ideas and access to a lot more garments. So I usually will ask the orthotist to come, and she will measure the child, and we'll make sure that they get a correct garment, because for their post-op care especially, it's really important that they have the garment so that they're getting that compression on the area that you have treated in theatre, to really maximize the benefits of what that will do. So it is sometimes quite tricky, again, especially because garments aren't made in South Africa. They all have to be made in Europe. So it takes quite a lot of planning to make sure that everything is measured on time, ordered in time, gets delivered on time. But so far, everyone's been happy with their garments, which is good.
Yeah, thank you. Thanks, Joss. I think it's nice just highlighting the side of venous that is not well known, and then some of the issues and how we all play a role. So you mentioned lymphoedema earlier, and the malformations. I think varicose veins are well known. Venous ulcers we treat a lot. I think maybe one of the newer things is treating patients with post-thrombotic limbs. So patients who have had deep vein thrombosis before, and now we are getting referred these patients more in the early stages. So patients are treated as an emergency if they develop a deep vein thrombosis, because clot can go to heart and lung and there's a risk of dying. But we always ignore the long-term effects, and that's where the post-thrombotic syndrome comes into play. And patients develop chronic swelling, discoloration, wounds, and then we will try now and intervene surgically to improve the leg, and that's very, very much a multidisciplinary, because Khaya will scan them plenty times. We need a baseline. We'll intervene often more than once, and Emily will manage the swelling and wound. So I think that's an important part, but more importantly is the awareness of it, because patients are now starting to come in the early phases where they can be given compression or have lymph drainage or, encouraged on activity to actually prevent that ever occurring. So I think that's another area that is gaining more awareness, but certainly needs a lot more, because we can prevent a lot of chronic issues. Last year, we touched as well on pelvic congestion syndrome with the gynaes to create some awareness. And I think this has slowly also increased over the last year, which, needs to more as well. Khaya, do you want to mention a little bit just what pelvic congestion syndrome is and what you would look for on scanning?
Okay, so with pelvic congestion is usually like when patients will come with some chronic abdominal pelvic pain and heaviness around this area. When also other gynae scans, the patient has been to a gynae, has excluded any other causes of the pain. So when the patient usually comes, so what you usually look at when the patient comes with those symptoms. So most of the time, we just have to look at the pelvic, or we do a pelvic scan, looking at the iliac veins to see if there's no maintenance or compression of the iliac veins, which can lead to pressure lower down the iliac veins into the lower limbs or into the internal iliac, which can cause pelvic varicosities. Or sometimes patients do decompress from the pelvic varicosities, so they start developing high thigh veins, or also other vaginal veins. So that's when you see patients with those veins. So there's highly likely something happening in the pelvis, whether you see the maintenance syndrome, or some patients do present with ovarian reflux. So that's what you usually see with those patients when they come up with those high thigh veins, or even posterior thigh veins, which are which don't have any, which are not usually involve the truncal veins like the great saphenous veins or the small saphenous veins. And also what can make us suspect that the patient maybe has maintenance or even pelvic congestion or ovarian vein reflux is when a patient has has done a lot of venous surgery, high venous stripping, GSV stripping, or even catheter treatment for the veins, but has developed a lot of recurrence. Patient maybe does 3 surgeries, but the veins always return, especially around the groin areas. So that might indicate that the patient might have problems higher up. So we always check those patients to check just to exclude that there's no maintenance or ovarian vein reflux. And also we've made it a standard for us, any patient which comes with from class 3 up, so we always check routinely the pelvic veins and the iliac veins, just to make sure that there's no contributing there's no contribution from the iliac veins or ovarian veins to the swelling. So like it's a standard in this practice now where patient with class 3 going up, we always check the abdomen and the pelvic area.
Okay, thanks, Khaya. Yes, I think that awareness is what importantly why we say you can't just have leg varicose vein clinics. You need to know what's going on often higher up. And if a patient has pelvic symptoms, they might have pelvic congestion syndrome, which means they've had chronic pelvic pain for more than 6 months, and it can be from something in the abdomen or pelvis. So pelvic varicosity, ovarian reflux, or any of the compression syndromes. So that is definitely becoming more recognized by our fellow gynaes. And the other area, I think superficial veins have been covered plenty times. The other area is lipedema for you, Emily. So with lymphedema, we've started to see more lipedema, which is more well recognized overseas, but definitely there's a lack of awareness here. It can be overdiagnosed for sure, but it can also be misdiagnosed as obesity or being fat. So do you want to just mention what that is, just to create a little bit of awareness around that?
Sure. So lipedema itself is an adipose tissue disorder. I have seen a few patients who have been diagnosed with lymphedema, whereas lymphedema is a lymph condition and a fluid condition. Lipedema, on the other hand, is not fluid. It's adipose tissue. So sometimes people are misdiagnosed like that, just because I think not as many people potentially know about it. Again, it's about raising more of that awareness of it. Some of our patients who come as well, a lot of them know quite a lot about lipedema already. They've done quite a lot of research themselves. They've come from places where they've tried to do things like lose weight. Lipedema tissue, though, is generally very unresponsive to any form of dieting or any type of exercise. So they come understandably really, really desperate for a diagnosis and to understand what's going on. There isn't any type of specific like medical test or diagnostic tool that we can use to absolutely definitely know that they have lipedema. We have put together a set of criteria, though, that we look at to help us diagnose it. So, for example, that'll be something like we look at their waist to height ratio. If that is less than 0.75, World Health Organization define that as being a disproportionate accumulation of fat tissue, and therefore is possibly suggestive that they have lipedema. Like I said, Khaya also does a lipedema scan for the patient to measure their the distances between all the tissues. We can look at that as well as either being suggestive or not suggestive of the lipedema. We also look at their tissue, and we look at the shape of their bodies as well. So they've devised stages and types of the condition, so we will look at that as well. And then I think probably the most frustrating thing for everyone is that there's no cure for it. So instead of it being a curative condition, it has to become more management orientated and lifestyle orientated. Again, Dr. Redman's devised a we call it the Optivane way, which looks at lifestyle factors to help people manage their condition. A lot of the time, patients will have very sensitive skin, and they will bruise quite easily. So it's things like that we have to help them manage. Compression is one of them. But again, compression is quite difficult for some of these ladies because it has to be custom made. And again, there's actually a cost issue involved. But again, it's not really a one size fits all either. So we always suggest to patients that they just try things as well to see what works for them. We've also started a lipedema support group, which is run by a psychologist, and that is every second week. So patients can join that and get support on anything that they would like. And it's a way for them to meet other people who have a similar condition to them. And I know that it's quite useful because they all share ideas about different ways that have helped them maybe like manage pain or manage some discomforts. So yeah, again, looking at our patients holistically. We don't only want to just make sure that they have no pain, but we also want to help them maybe to deal with it more on a social level, on a psychological level. So that's where the outside psychologist comes in.
Thanks, Emily. So I think you touched again on the importance of multidisciplinary team, and then links to other ones. So I suppose it's multidisciplinary and not to be in isolation. And just also for listeners, because of the lack of awareness, I'll just add on to what you said with lipoedema. I also always explain to patients, it is a condition that happens in women. It's basically abnormal or disproportionate, like you said, accumulation of fat, but it's in the female distribution. So they gain weight in the hips, thighs, and up to the ankles, spares the feet as one of the clinical signs, sometimes in the upper arms. So if they lose weight, they'll lose it on their abdomen or upper body. And patients have got almost anorexic on the upper body and still had these large limbs. So it's a definite pathological condition. We know there's a hormone influence because it occurs in women unless there's derangements in the men, although there's no specific hormone level or deficiency that causes it. Hormone resistance has been looked at. It's also been described as a connective tissue disorder because the fat is pathologically different or histologically different from normal adipose tissue. And patients have fragility of capillaries and small vessels, so they bruise easily. And we've definitely seen it that their limbs are more tender and they have more inflammation. One of the risk factors for it is weight gain. So explain that is a problem. They gain weight, and then in those areas, they really, really struggle to lose it. So weight management, as frustrating as it is to tell them, is part of it. So we also explain a patient can have lipedema and they can be overweight or obese. So that side you can manage. And I think that also brings me to the point of let me actually, before I get there, Khaya, do you want to quickly mention what you look for on the lipedema scan? We do, again, there's no diagnostic tool, but we combine clinically, symptomatically, and then your radiologically, and see if they're more than likely can be diagnosed with lipedema. So just mention the scan.
Okay, so what I usually look for is just like from the, as Dr. Redman says, like the first distribution is around like the gonadal areas. So like I found an interesting paper from overseas, which was trying to like use ultrasound as the diagnostic tool for lipedema. So they did a study like for all BMI groups. Then they did like found the cutoff values for the thickness of those areas, which I'm gonna just mention now. So the first area is just the anterior thigh, just a mid portion from above the knee. So I just measure like the adipose thickness from the muscle, then to the skin. Then what the other areas, which was with lipedema patient, where like usually like there's an accumulation first, is the peritibial areas just below the knee on the medial side. So that's also the area which I do measure the thickness from the skin to the muscle, and also the perimalleolar area. So like that's what we see with lipedema patient, like there's ankle cutoff sign. So the perimalleolar is the ankle joint. That's where like also the fat deposition happens. So that's where area we measure. So there's also the thickness there, which I measure. So like there are those values which I do measure. If it's above the cutoff, then it's usually like will indicate that the patient is highly likely has lipedema. So it's kind of like it's still fairly new. So it's still like still more research to be done, but like for now we just like use it in conjunction with the clinical diagnosis of lipedema. Then like it can like make it more likely that the patient has lipedema, not just obese patient.
Okay, excellent. Thanks, Khaya. Okay, and I think the last point to mention for awareness of venous and lymphatic is aesthetic phlebology. So the aesthetic side of veins, we do treat some varicose and mostly spider veins aesthetically. Also, hand and face veins can be included. And that's when we left with one person in our multidisciplinary team will join us as a plastic surgeon. And the lipoedema reminded me of that as well, because some patients do eventually do liposuction, which will be done by a plastic surgeon. So with that, I think we've highlighted the whole overview of venous and lymphatic disease and the benefit of having a multidisciplinary team, and the team working together and looking about lifestyle and preventative medicine as well. So thanks for joining, and we'll be back with another vein podcast soon.